All right, today we're going to talk about aortic dissection, super high yield topic for both step 1 and step 2. This will be the only aortic dissection lecture you'll ever need. I'm going to teach you everything you need to know to be able to rock and roll on these board exams and for real life. I know what I'm talking about because I've got glasses on, so that must mean I'm smart, right? So let's ride. Objectives, we're going to talk about what is aortic dissection. We'll do the pathophys, the Stanford system, management, complications. We'll talk about cyanide toxicity. You'll see why in a second, and then putting it all together. So I offered this case on Instagram this morning, had a lot of good responses. So let's see what you guys come up with. So we have a 56-year-old man presents with tearing chest pain that radiates to his back. He's diagnosed with Stanford type B aortic dissection. Given his history of asthma and COPD, appropriate pharmacological therapy is initiated to achieve blood pressure control. 24 hours later, the patient becomes confused. His respiratory rate's 28, blood pressure 85/50, heart rate 90. Physical exam reveals no focal neurological findings other than altered mental status. His extremities are warm. Venous blood is drawn for laboratory testing, and the phlebotomist notices that it appears bright red. I want you to think about what is the underlying cause and how should we treat this patient. So pause your screen, consider it, and I'll move on. So this patient likely has cyanide toxicity secondary to nitroprusside use. The nitroprusside should be stopped, and we should start hydroxycobalamin as first line, or we could use sodium thiosulfate / sodium nitrate as second line. We're going to unpack this answer kind of as the lecture progresses. We need a lot of background information before we kind of unpack this answer. All right, so let's get into it. What is aortic dissection? Aortic dissection is a life-threatening condition where we tear the aortic intima. It allows blood to enter into the media layer, creating a false lumen. So remember, in my blood vessel, we have the intima on the inside that's in contact with the blood. The media surrounds it, and then surrounding the media is the adventitia. So normally blood is flowing through this lumen, touching the intima, but when we have certain risk factors like hypertension, the most common, certain connective tissue disorders that make my vessels less intent, like less rigorous, less rigid, more flimsy, we can get tearing of this intima. Okay, the intima tears and blood flows in through the media. When blood flows into the media, we form this false lumen. Okay, so blood is now flowing through this false lumen. It normally should be flowing through the intima. Now it's forming through the gap between the intima and the media. When this happens, it can cause the false lumen to expand, and then that can lead to compromising the blood flow to vital organs, and then this can lead to rupture or tamponade. So again, certain risk factors. Hypertension is by far the most common risk factor. It is the go-to step 1 question for aortic dissection. They'll give you a patient with aortic dissection and say, what was the most important risk factor in this patient? It's always hypertension, right? Maybe they give you the rare case where the patient doesn't have hypertension and they have one of these connective tissue disorders, then you can answer that. But the classic question is a patient with pretty uncontrolled hypertension. That causes the intima to tear. Blood flows through the intima into the media. We form this false lumen. The false lumen expands. It can form thrombi, and it can then cut off blood supply to certain really important organs like my brain, my mesenteric arteries, my kidneys, right? All of that. So epidemiology, it's usually 3 to 4 cases per 100,000. More common in men, typically 60 to 80. Hypertension, again, the most common cause. So think about my heart has to pump really hard and really fast to counter this increased afterload of high blood pressure. We're going to shear across this intima, and over time, that's causing a lot of damage, and then we end up tearing the intima. Blood moves into the medial layer, causes this false lumen, expands, cut off blood supply. Again, connective tissue disorders like Marfan or Ehlers-Danlos lead to really flimsy collagen that make up a lot of my vessels, or that make up my vessels, right? Especially like the aorta, and it can lead to a flimsy aorta that's just asking for that intima to get torn. With regards to bicuspid aortic valve, right, that's a common risk factor, and so is trauma. You may have remembered like bicuspid aortic valve is a common cause of early aortic stenosis due to early calcification of that valve. It's also an early cause of aortic regurg, right? And so similarly, it can lead to a flimsy aorta in itself, an aortic arch that can lead to an early onset of aortic dissection, or at least predisposed. Remember with my aortic stenosis, what is that murmur going to sound like versus a murmur of aortic regurg? So pause your screen and think about that. So aortic stenosis is classically a systolic crescendo decrescendo, heard best at the right upper sternal border. It can radiate to my carotids. It can lead to a delayed pulse in my periphery. So that's called pulsus at tardis, right? You might see that. Aortic regurg can be heard both at the right upper sternal border and left upper sternal border. It is classically a diastolic crescendo decrescendo murmur. We can classically get the widened pulse pressure. We can get the head bobbing, right? Classic signs like that. We can get like the water hammer pulse, so the pulses are really strong. With regards to aortic regurg, if I hear it best at the right upper sternal border, it's likely due to a root dilation, so the aortic root dilation. If it's heard best at the left upper sternal border, it's usually due to valvular damage. All right, let's move on. We can classify aortic dissection using the Stanford classification. There is something called the DeBakey classification. It's less commonly used, so I'm only teaching the Stanford classification because that's what's going to show up on USMLE STEP, and that's what you're going to use in real life. So type A, it involves the ascending aorta, right? That's the easy way to remember it. It can include the arch and the descending aorta, but if the dissection involves the ascending aorta, we call it a type A. That is a surgical emergency. We act now. If it's type B, it doesn't touch the ascending aorta. It involves the descending aorta only, distal to the left subclavian artery. It's typically managed medically unless complications arise. So again, type A has to involve the ascending aorta. It can extend into the descending aorta. Surgical emergency, go, go, go. Type B, it doesn't touch the ascending aorta. It picks up after the left subclavian artery. We typically manage it medically unless complications arise. I've got a nice picture for you guys here. So here, the ascending aorta, here, the descending aorta, here's my tear in the intima, my tear in the intima. So this guy has, you tell me, this guy has a tear in the intima here in the ascending and a tear in the intima in the descending. Would we call this a type A or a type B? And what would be your next best step? So because the ascending aorta is implicated and the descending, we by definition call this a Stanford A. We go, 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 go to surgery. All right. So major risk factors, I've already kind of talked about this, but it needed to be harped on again. Chronic hypertension, chronic hypertension, chronic hypertension. You see a patient with poorly controlled hypertension, and then some of these presenting signs and symptoms I'm about to talk about immediately need to be thinking about aortic dissection. Again, connective tissue disorders like Marfan, which is a fibrillin 1 defect, or Ehlers-Danlos, a type 3 collagen defect. Collagen makes up my backbone of my my vessels, and it can lead to a very flimsy vessel just asking for a tear. Bicuspid aortic valve, pre-existing aortic aneurysm, atherosclerosis can contribute. Coarctation of the aorta will lead to increased afterload and increased hypertension. We do have iatrogenic causes, so like cardiac cath and cardiac surgery. Trauma, like a rapid deceleration injury. So if a patient is driving a car, gets into a crash, and we have a rapid hit of the mediastinum against some sort of hard surface like the wheel or the dashboard, can absolutely cause a tear in the intima. And then pregnancy is rare, but it's possible, especially in Marfan patients, right? Because these patients are going to get volume overloaded during pregnancy, right? In pregnancy, the women have to increase the amount of volume because they're now supplying the fetus. That can lead to overload through the aorta. It can cause stretch and then tear of the intima as well. All right. So the classic symptoms, this is what I was getting at. You'll classically see chest pain that's sudden in onset and really severe. It usually feels like a tearing or ripping. That's opposed to like an MI that usually feels like more like a substernal pressure, like something's pushing on their heart. This aortic dissection feels like a tear or a rip. It may radiate to the back, abdomen, or neck, depending on the location. Sometimes you could have neurological symptoms like syncope, stroke, or hoarseness if the recurrent laryngeal nerve is impacted. Again, think about where this dissection is happening. It's happening in the ascending aorta, which is really close to my internal carotids. So if the internal carotids are implicated, we can lead to stroke, right? Because now we have this false lumen extending. We're not getting blood supply to my circle of Willis, right? The internal carotids turn into the MCAs, and then we feed the entire rest of my brain circulation. So we're cutting off supply to the brain. And then the recurrent laryngeal nerve is right around my aortic arch. Remember, it swoops under. And it likes to run like under the aortic arch, and then it will supply the muscles of my vocal cords, right? Other than what, right? This is what I was kind of getting at, is the recurrent laryngeal nerve will supply muscles of my vocal cords other than what major muscle? So that's going to be the cricopharyngeus, right? Classic step 1 question, maybe not so much step 2. The cricopharyngeal muscle is innervated by the superior laryngeal nerve. You could also see heart failure symptoms if the aortic regurg impacts, or if the aortic dissection impacts the aortic valve and then can cause aortic regurg. So you might hear a new diastolic murmur, right? Diastolic crescendo, decrescendo. We could get abdominal or flank pain if it extends into the abdominal aorta. On a physical exam, we could see a blood pressure differential between arms. That's if the dissection has now extended into usually the left subclavian artery. So we're cutting off blood supply to the left or to the left arm. The right arm still getting perfused, so we could see that blood pressure difference. We could see the pulse deficits for the same reason. Again, I already talked about the new diastolic murmur. We could see signs of tamponade if the dissection has now progressed and gotten itself into the pericardium. So we could see Beck's triad, where we see hypotension, JVD, and muffled heart sounds. And then we could see neurological defects, like I was talking about, if we impact the carotids. So again, patient with poorly controlled hypertension or a history of Marfan or Ehlers-Danlos are going to be classic. You're going to see chest pain that tears, radiates to the back. You might see syncope or stroke. You might see tamponade. You might see abdominal pain. You might see a new diastolic crescendo, decrescendo murmur. Again, and then we might see blood pressure abnormalities in each arm. So all things to consider. If we see some of these, we got to consider aortic dissection. So what are my key diagnostic tests? This is classic for step 2. If the patient is stable, so let's say their blood pressure is 130 over 90, right? Perfectly stable. We suspect aortic dissection. We run them through a CT angiogram. Again, that's going to help us really see the vessels. It's rapid, it's highly sensitive and specific. If the patient is unstable, or we're at bedside and we're thinking about going right to surgery, we can do a TEE. So that's where we stick the scope down the throat and we can see different angles of the heart that we can't fully see with the TTE. So it shows us more of like the backside of the heart, right? Because what sits on the esophagus is like my left atria, and then we'll get a nice view of the aortic valve and the aortic arch, right? The ascending aorta. It'll give us a beautiful view. So again, first line for a stable patient with suspected aortic dissection, CT angiogram. First line for a suspected patient with unstable aortic dissection, TEE, usually on the way to surgery or in the OR itself. MRI angiography is the gold standard, but remember, MRIs take a long time to work. CTs are really quick, TEEs are really quick. So that's why, like, in theory, MR angiography is the gold standard, but we're never going to do it. It's going to be CT angiogram if the patient's stable, TEE if they're unstable. Labs, we really don't need to get labs, but we could see an elevated D-dimer. We might see an elevated troponin if we've involved the coronary arteries. We could see an elevated creatinine if we have renal perfusion problems. EKG is kind of a must-need, right? Obviously, any patient with chest pain, we're probably going to get an EKG on them. It's often normal. We may see non-specific ST or T changes. We need to do it to rule out an MI, right? Because the management is completely different, and it's a must rule out, all right? I'll do a whole lecture on chest pain later. Medical management, super important, right? So the initial stabilization, beta blockers, beta blockers, beta blockers. Every patient with new aortic dissection gets a beta blocker, even if we're going to surgery, right? It's always first line. Esmolol is great. It is the preferred option for rapid titration. Labetalol is also a good option. It's got dual alpha and beta properties. Our goal heart rate is less than 60 beats per minute. Vasodilators, right? So maybe the beta blockers don't work, or the beta blockers are contraindicated. Like our patient in our case that I gave you at the start, they had a asthma and COPD. And remember, beta blockers, right? My beta 2 receptor, it needs to be activated to cause bronchodilation. If I give a non-selective beta blocker that causes the blockade of beta 2, it's going to lead to bronchoconstriction. I give that to a patient who's got normal physiology, not much is going to happen. I give that to a patient with bad asthma and COPD. We've just exacerbated their system, and now they're going to have a hard time breathing, right? So beta blockers, non-selective beta blockers are relatively contraindicated in patients with asthma and COPD. Not a great option. So that's when nitroprusside can be used. We use it cautiously. Remember, nitroprusside is both an arterial and venous dilator. It's going to work really well to lower that blood pressure. We'll try to get that blood pressure between 100 to 120 systolic. Pain control, we can use IV opioids. So again, medical management, beta blockers first line, esmolol is preferred. It can do rapid titration. Labetalol can also be used. It's got dual alpha and beta properties. We're going to try to aim for a heart rate less than 60. If the beta blockers aren't working, or if we have a contraindication to beta blockade, we can consider nitroprusside, an arterial and venous dilator. We want to get that blood pressure to 120. We can give opioids if needed. So again, remember, once we give the beta blockers, if this is ascending, we go to surgery. If it's descending, Stanford B, we can just continue to medically manage and watch. All right, complications. This is a very high yield slide. So I've already talked about a lot of these, but we could get aortic rupture, which could lead to hemopericardium. So now blood is flowing into the pericardium. That can lead to tamponades. Remember, tamponade physiology. We have fluid that's compressing the pericardial space. And now all of a sudden, my pressure is sifting down and it's sinking in on all four of my chambers. And now all of a sudden the diastolic pressure in all four of my chambers will equalize. Okay. That pressure is sinking down equally all across it, because here's my heart, here's my pericardium, and that fluid is just around all equally pressing down. The diastolic pressure is the pressure that helps blood move through. Okay. So it's my filling pressure. If my diastolic pressure is equal in all four chambers, we're not going to have any movement of fluid, and the patient will go into cardiogenic shock. That means the heart is not able to pump fluid out into the system. So remember, for cardiac tamponade, we're going to need to stick a needle into the pericardium and remove that fluid, right? It's called a pericardiocentesis. When I do my chest pain lecture, we'll talk more about tamponade too. We could see aortic regurg again if the aortic dissection infiltrates the aortic valve. So again, a diastolic crescendo decrescendo murmur heard at the right upper sternal border if it's the root is impacted, or the left upper sternal border if the valve is impacted. We could see stroke or neurological defects if we've extended into the carotid or even the vertebral arteries. We could see spinal cord ischemia if we've impacted the anterior spinal artery, which is somewhat common. And then we could see end organ ischemia. We could see renal failure, mesenteric ischemia, limb ischemia. Late complications, right? We could have a patient who has a chronic dissection, aneurysm forms, so just dilation of the aorta itself, progressive dilation and rupture, and redissection. So again, watching for aortic rupture and tamponade, aortic regurg, coronary artery involvement leading to MI. So I think I skipped over that one. If we have aortic dissection, it can extend into the coronary arteries itself and then cut off blood supply to the myocardium, right? So then we will essentially have an MI, right? Stroke or neurological defects or spinal cord ischemia, and then obviously all of our end organ damage. All right. So this is the cyanide toxicity, kind of bringing it back to our question, right? So the pathophysiology from my question, right? The source was metabolizing of sodium nitroprusside releases the cyanide ions, right? And I've got a slide next going deeper into the pathophys because I think it's really important and cool to kind of learn about that. But the mechanism is when nitroprusside is broken down into cyanide, the cyanide binds to cytochrome C oxidase, which is complex 4 in the mitochondria. That inhibits the oxidative phosphorylation. It forces us into anaerobic metabolism, because remember, oxidative phosphorylation in the mitochondria is what helps us do aerobic metabolism, right? Make ATP. We don't do that. We have to rely on anaerobic metabolism. And by default, whenever we do anaerobic metabolism, we make lactic acid. So the patient will have lactic acidosis. Remember in one of my more recent videos on OSMO-GAP, I talked about anion gap metabolic acidosis. So the new mnemonic is GOLDMARK. The G is glycol, so ethylene and propylene glycol. The O is oxoproline, which is a metabolite of acetaminophen. The L is L-lactate, which would be this case. The D is D-lactate, which we could see in SIBO. The M is methanol. The A is aspirin. The R is renal insufficiency, and the K is ketoacidosis. I go into more of the etiology on those in that OSMO-GAP lecture, so go watch them. So this will lead to anion gap acidosis. My tissues now will have impaired tissue oxygen extraction. So the venous blood remains oxygenated, it remains bright red. That's why our phlebotomist saw bright red blood, because normally our tissues are able to take out, when the arteries send blood to the tissues extract the oxygen and then send the deoxygenated blood back to the venous system, back to the heart and lungs, right? In this case, because of the cyanide inhibiting cytochrome C oxidase, the tissues aren't able to effectively take out the oxygen. So more oxygen makes its way to the capillaries and then to the venous system. So when my phlebotomist is drawing blood from the vein, that blood's going to appear bright red. All right. So clinical features, we could see altered mental status, confusion, seizures, like we saw in our case. You could see hypotension. We could see tachypnea, metabolic acidosis, a high anion gap, elevated lactate, bright red venous blood, and then everyone's favorite that they probably memorized. We could see cherry red lips and an almond taste. Those are very unreliable tests, so don't be looking for them in vignettes and don't be looking for them in your patient. Obviously, if you see them, it points me towards that direction, but they're unreliable. So really, altered mental status, hypotension, metabolic acidosis, elevated lactate, bright red venous blood are all really good signs, and then your tachypnea too. Risk factors, high dose of nitroprusside, if there's a prolonged infusion or renal hepatic dysfunction. So to break down this pathophys just a little bit more, so where does the cyanide come from? Each molecule of sodium nitroprusside contains 5 cyanide groups. When nitroprusside is infused, it rapidly donates nitric oxide, which causes vasodilation, but that releases the cyanide ions into circulation, okay? Normally, small amounts of that cyanide are detoxified easily. High doses, though, that we sometimes need to use in aortic dissection to control that blood pressure, prolonged infusion, or impaired detox capacity in the kidney and liver can lead to cyanide accumulating. So normal cyanide detoxification, the liver converts cyanide to thiocyanate using the enzyme rhodinase, okay? This requires adequate sulfur donors, and thiocyanate is excreted by the kidney. So in liver dysfunction, we have impaired conversion to thiocyanate. In renal dysfunction, that thiocyanate builds up because we can't get rid of it. If we use up all of our thiosulfate, the detox pathway becomes overwhelmed. So what does cyanide do at the cellular level? Well, it binds irreversibly to cytochrome C oxidase. We've already talked about this in the ETC. It shuts down oxidative phosphorylation. The oxygen can no longer serve as the final electron acceptor, so the electron transport chain collapses and ATP generation halts. So what does our body do? Our body has to rely on anaerobic glycolysis. To do anaerobic glycolysis, the end step, we make lactic acidosis. That lactic acid we make lactate. That lactate builds up and it leads to lactic acidosis. The venous blood again is bright red because the tissues can't extract oxygen because the electron transport chain is blocked. The oxygen content remains high in the venous blood. So that results in the arterial O2 is normal because we're still able to oxygenate the blood, okay? It gets to the tissues, but there's less tissue extraction of the oxygen. So the venous O2 is abnormally high, which leads to bright red venous blood. So again, there's no problem getting oxygen in through my lungs, bound to the hemoglobin. So the arterial O2 is totally fine, but it's a problem at the level of the tissues. The tissues can't extract the oxygen. So more oxygen remains in the blood that makes its way to the capillaries in the venous system. So then when we look at the blood, right, it's going to be bright red because it's more oxygenated. So it's very similar to carbon monoxide in that respect. Carbon monoxide will be a topic for another day. All right. So diagnosis and management for cyanide toxicity, primary clinical, right? If our story fits, right? Other things that can lead to it are like smoke inhalation. So look for a patient who was like recently in like a fire. That's like a classic example. If they have elevated lactate, metabolic acidosis. Our management, immediate discontinuation of the thing that set it off, right? In this case, nitroprusside. Antidotes, hydroxycobalamin is first line per the American Heart Association. Sodium thiosulfate can be used as well, and sodium nitrate is like rarely used now. So how do these antidotes work? Hydroxycobalamin is a vitamin B12 precursor. It directly binds to cyanide. It forms cyanocobalamin, which is B12, and then that's safely excreted. So again, we have this vitamin B12 precursor. It binds to cyanide, which forms B12, which is safely excreted. This is safe, it's fast acting, and is now the first line antidote. Just to, for completeness, sodium thiosulfate donates sulfur to enhance the rhodinase-mediated conversion of cyanide to thiocyanate. So remember I showed you here, we convert in the liver to thiocyanate and then pee it out via the kidney. So sodium thiosulfate helps with that. And sodium nitrate induces methemoglobinemia. Remember, methemoglobinemia, we have turned the Fe2 plus in the heme to Fe3 plus. that Fe3 plus binds cyanide super tight, so cyanide can no longer go to the oxygen, to the electron transport chain and bind to cytochrome C. So it removes cyanide from circulation. Again, this one's like rarely used. So again, hydroxycobalamin, precursor to B12, directly binds cyanide, forms B12, which is safely excreted, and then sodium thiosulfate donates a sulfur group to enhance the rhodonase-mediated conversion of cyanide to thiocyanate that then is renally excreted. All right, almost done. That was pretty much everything. So now here's our putting it all together. We have a 56-year-old man with a history of hypertension presents to the ED with sudden onset severe tearing chest pain radiating to the back. He's diaphoretic and appears distressed. On exam, his blood pressure is 80/50, heart rate's 120, JVD is present, and heart sounds are muffled. Pulses are diminished in the left arm compared to the right. Bedside echocardiography reveals a large pericardial effusion with right atrial and right ventricular diastolic collapse and a dissection flap in the ascending aorta. Which of the following is the most appropriate management? Should we do emergent pericardiocentesis? Should we do intravenous beta blocker and vasodilator therapy only? Should we do emergent surgical repair of the ascending aorta? Should we do thoracic endovascular aorta repair? Or should we do observation and serial echo? So pause your screen, think about everything we've talked about, reread the vignette if you need to, and come up with your answer. So in this case, we're definitely going to want to go do emergent surgical repair of the ascending aorta. So this comes straight from the American College of Cardiology and the AHA's guidelines for aortic root disease. So just looking back, does everything jive with aortic dissection, right? We've got a relatively older man, like 56. He's got this history of hypertension. Remember, the most common risk factor. He's got this sudden onset severe tearing chest pain radiating to the back. Everything's clacking out, right? Like working out perfectly the way we've talked about it. His blood pressure is low, his heart rate is elevated, and he's got JVD and muffled heart sounds. That should key you in on Beck's triad. We should think about, okay, did this aortic dissection now extend into the pericardium and cause hemopericardium and cardiac tamponade? Sure, looking like it, right? We see pulses are diminished in the left compared to the right, and we already know that, right? The dissection can extend into the left subclavian and cause decreased blood flow to the left arm, right? Classically, working out, we see a large pericardial effusion. Everything's working out. We see we've impacted the ascending aorta. So the key here is because we've impacted the ascending aorta, it's a Stanford A. So we're going to need to do some sort of surgery, right? Now, emergent pericardiocentesis may seem like an intriguing option, right? But the ACC and the AHA say for aortic dissection that has now caused cardiac tamponade, we go right to surgery, okay? Surgical repair is the definitive management, as medical therapy alone is associated with extremely high mortality. We are going to give the patient beta blocker and vasodilator therapy. The thing that makes this answer wrong is I say only. We're not just going to give them intravenous beta blocker and vasodilator. We're going to give them one of those or both of those, and then we're going to go to surgery, right? And honestly, in this case, we're probably not like for most aortic dissections, as long as they're not like hemodynamically unstable, because this patient's blood pressure is already 80/50, I'm actually probably not going to give them that, right? Now thinking about it. With regards to pericardiocentesis, it's generally reserved only as a bridge to surgery in cases of impending cardiac arrest. It actually may worsen the hemodynamics by causing increased bleeding from the aortic rupture. So emergent pericardiocentesis would actually probably make things worse in this case, right? Looking at the literature, if you have cardiac tamponade from any other reason, pericardiocentesis is likely the right answer, right? Likely the right move. When you have aortic dissection leading to cardiac tamponade, sticking a needle into the pericardium is probably going to cause further aortic rupture and only make things worse. Again, initial medical therapy would be appropriate in most cases. Obviously, in this case, where the patient's blood pressure is 80/50, not going to work. And because it only says only, we need to do more, right? At Stanford A, we need to do surgery. TEVR, thoracic endovascular aortic repair, is not indicated for type 1 dissections. We did not talk about that at all. Not the right answer. And then observation is obviously inappropriate due to the risk of rapid deterioration. So hopefully all that makes sense. We have an aortic dissection. It extended into the pericardium. We cause cardiac tamponade. Normally for most tamponades, pericardiocentesis is the right answer. For tamponade secondary to aortic dissection, pericardiocentesis is not a great option because we can rupture the aorta. We can like further damage the aorta, and that can lead to worsening hemodynamics. So when you have a patient with aortic dissection leading to tamponade, right to surgery. Okay. Beta blockers and vasodilators are classically used. Look at the patient's blood pressure, right? In this case, 80/50, not going to be a good option. Not going to be a good option on its own, also, if it's type A. So hopefully that all makes sense. So summary, again, aortic dissection is going to be caused by an intimal tear leading to a false lumen, risk of rupture, and then ischemia. We can call it type A, where it's ascending, leading to surgery. Type B is descending, we medically manage, right? Risk factors are going to be hypertension, Marfan's, Ehlers-Danlos, bicuspid aortic valve, and trauma. Symptoms, we see that sudden tearing chest pain, back pain, maybe the pulse differences in the arms, maybe the BP differences, maybe neuro deficits due to the ICA, maybe new aortic regurg due to damage to the aortic valve, maybe new tamponade due to hemopericardium. Diagnosis, if they're stable, is a CTA. If they're unstable, is a TEE. Treatment, beta blockers first, right? Like esmolol is our go-to. We can also use labetalol. If both of those don't work or they're contraindicated, we can use nitroprusside. We do, again, surgery for type A, medical for type B. Watch out for tamponade, MI, stroke, renal failure, mesenteric ischemia, and then cyanide toxicity with nitroprusside. And again, for cyanide toxicity, it's cyanide inhibits cytochrome C oxidase. We lose the ability for oxygenation in the electron transport chain. We can't make ATP. We're shifted over to anaerobic glycolysis. We make more lactate. We get lactic acidosis. The patient can become confused. They can have hypotension. They can have tachypnea. They'll have metabolic acidosis, high anion gap. With regards to that, we treat with hydroxycobalamin, which will be the first line, right? Which will convert cyanide plus hydroxycobalamin makes B12. We pee it out. Or we could use sodium thiosulfate as like a second line, which helps us convert cyanide into thiocyanate, which can also be peed out. So if you want to read more, here is the newer guidelines, the 2022 guidelines. That's as new as we get for aortic dissection. So you can screenshot that and throw that into Google. And if you want to read more, here's a DOI from cyanide toxicity. So I use both of these to make this lecture. So we covered literally everything you would need to know on aortic dissection in 30 minutes. So hopefully this was really helpful. I try to tackle it from many angles. Send me an email. Let me know your thoughts. Send me topics you want me to cover. All right, till next time.